Hello everyone, welcome to my YouTube channel. Today I am going to talk about part 2 of wound healing. In this part 2 video, I am going to cover especially regarding the local factors that affect the wound healing. Before we start, there is a disclaimer, and the disclaimer is the same in all my videos. Now let's begin. I want to revise regarding the wound healing phases or process. It consists of 4 highly integrated and overlapping phases. The first stage is hemostasis, followed by inflammation, proliferation, and lastly, tissue remodeling or resolution. These phases and their biophysiological function must occur in proper sequence at a specific time and continue for a specific duration at an optimal intensity. In hemostasis phase, there is a vascular constriction, platelet aggregation, degranulation, and fibrin formation, thrombus. In inflammation phase or inflammatory phase, there is neutrophil infiltration, then later monocyte infiltration and differentiation to macrophage. Lastly, there will be lymphocyte infiltration. In proliferative phase, first, there is reepithelialization that occur. Second, formation of new blood vessels, angiogenesis, then collagen synthesis will occur with end of proliferative phase by extracellular matrix formation, ECM. In tissue remodeling or resolution phase, there will be collagen remodeling and later vascular maturation and regression. There are many factors that can affect wound healing which interfere with one or more phases in this process, thus causing improper or impaired tissue repair. Generally, the factors that influence repair can be divided into local and systemic factors. Local factors are those that directly influence the characteristic of the wound itself, while systemic factors are the overall health or disease state of the individual that affect the patient's ability to heal. Many of these factors are related, and the systemic factors act through the local effects affecting the wound healing. In this part 2 video, I am covering regarding the local factors that affect the wound healing. Among the local factors that involve are 1. Oxygenation, 2. Local infection, 3. Presence of foreign body, 4. Venous insufficiency, 5. Local radiation, and 6. Necrosis. In part 3 video of wound healing, I will cover regarding the systemic factors that can influence the wound healing. Among the factors are age and gender, sex hormone, stress, ischemia, disease that the patient have, example, diabetes mellitus, liver failure, medication that the patient taking, example, either steroids, either it contain non-steroidal anti-inflammatory drug, NSAIDs, chemotherapy drugs, alcoholic patient, nutrition, and immunocompromised condition, example, cancer or AIDS. Regarding local factors, how does each of the factor affect the wound healing? In 1. Oxygenation. Oxygen is important for cell metabolism, especially energy production by means of ATP. Oxygen helps in prevents wound from infection by the action of polymononuclear PMN leukocytes that depends on oxygen level. B. Oxygen-induced angiogenesis, Angiogenesis again is formation of new blood vessels. C. Oxygenation increase keratinocyte differentiation, migration, and reepithelialization. Oxygenation enhance fibroblast proliferation and collagen synthesis. And D. Oxygenation promotes wound contraction. Thus, proper oxygen level is crucial for optimum wound healing. In summary, in wounds where oxygenation is not restored, healing is impaired. Temporary hypoxia after injury triggers the wound healing. Example, by the release of growth factors and angiogenesis. But in the event of prolonged or chronic hypoxia, this will delay the wound healing process. Oxygen is needed to sustain the healing process. In local factor number 2, infection. Once the skin is injured, microorganisms that are normally in the skin surface obtain access to the underlying tissues. The state of infection and replication status of the microorganism determine whether the wound is classified as A. Contamination, B. Colonization, C. Local infection or critical colonization, or D. Spreading invasive infection. A. Contamination. Contamination is defined as the presence of non-replicating organism on the wound. B. Colonization is defined as the presence of replicating microorganism on the wound without tissue damage. For C. Local infection or critical colonization, it is an intermediate stage with microorganism replication and the beginning of local tissue response. Invasive infection is defined as the presence of replicating organism within a wound with subsequent host injury. In inflammatory phase, it is a phase where the cellular inflammatory response acts to remove any cell debris and pathogens present. If the microbial clearance is incomplete, the inflammatory phase will be prolonged. Both bacteria and endotoxin can lead to the prolonged elevation of the pro-inflammatory cytokines such as interleukin-1 and tumor necrosis factor alpha, TNF-alpha. That this will prolong the inflammatory state. If this continues, the wound may enter a chronic state and fail to heal. In a prolonged inflammatory state, there will be a rise in the level of matrix metalloprotease, MMPs, a family of proteases that can degrade the extracellular matrix. This shift in the protease balance can cause growth factors that appear in the chronic wound to be rapidly degrading. Bacteria in the infected wounds also forms biofilms that will protect the organism and will be more resistant to conventional antibiotics. Number 3, foreign body. A small amount of foreign debris in a wound provoke an inflammatory response in an effort to eliminate or contain the invader. Large quantities and quantities of devitalized tissue, foreign debris, bacteria, and other irritants present within the wound will intensify this protective mechanism. Extensive or prolonged inflammation delays the wound healing and destroys the surrounding soft tissue and sometimes does involve bone. If the body fails to dissolve or extrude the foreign material, it may become encapsulated within a fibrous tissue. Once a retained foreign body is encapsulated, inflammation subsides. The type, timing, and intensity of an inflammatory reaction are determined primarily by the chemical composition and physical form of the foreign object. Materials that is inert, such as glass, metal, or plastic, may not elicit any abnormal tissue response. Objects with smooth, non-porous surface produce less inflammation and fibrosis than those with rough surfaces. Most metals are inert, but those that oxidize will cause mild to moderate inflammation. Vegetative foreign bodies, such as wood, thorns, may trigger severe inflammatory reactions. Number 4. For venous insufficiency that contribute to the local factors of delayed wound healing. Normal healing of acute wound usually needs through an orderly and time-based reparative process that promote the restoration of the anatomic and functional integrity of the skin. On the contrary, chronic wounds, example in venous leg ulcer, are usually arrested in the prolonged inflammatory phase, thus blocking the progression towards the neck phase and preventing wound closure. Chronic wound leg ulcer provide a fertile breeding ground for the onset of several complications, example, immobility and reduced quality of life, cellulitis, osteomyelitis, and neoplastic transformation. Venous insufficiency requires compression to the affected limb through the use of bandaging or stockings, which improve circulation and can aid in the exchange of molecules from the wound site. However, compression therapy often involves uncomfortable levels of pressure that lead to low patient compliance following closure of a chronic wound. This will result in wound reoccurrence. Number 5. Local radiation to the skin. Ionizing radiation is commonly used along with the surgical resection and chemotherapy in the treatment of solid tumors. Irradiation of overlying normal tissue, whereby the skin is an organ tissue with a high cell turnover, will be affected. Radiation disrupts the normal process of wound healing at various stages. Pathologic changes include cellular depletion, extracellular matrix changes, and microvascular damage resulting in local tissue hypoxia. This will lead to healing impairment to chronic fibrosis and later tissue breakdown. Acute skin injury following radiation can persist for days to weeks. It is characterized by transient erythema and tenderness, dry and wet desquamation, hyperpigmentation, mucositis, and early ulceration. Late radiation injury is a process of fibrosis, which can manifest as tissue atrophy, necrosis, vascular damage, and chronic ulceration. Wounding the skin by surgery or trauma can result in delayed healing or tissue breakdown. And lastly, number 6, regarding necrosis. Devitalized necrotic tissue can delay healing. There are two types of necrotic tissue that may appear in a wound. There is 1 slough and 2 eschar. Slough is a moist, loose, stringy necrotic tissue that is typically yellow. Eschar, which appear as dry, thick, leathery tissue may be black. In most cases, necrotic tissue must be removed before repair and healing can occur. Okay, that's all for today. We already covered regarding the local factors that affect wound healing in this video. In part 3 of wound healing, I would cover regarding the systemic factors that affect the wound healing. I hope that you have learned something from this video. Till we meet again, see you and bye.